Oh, thank you. Also, thank you for the introducing words, Wendy. It's a pleasure for me to be here and to, also give my part in this ESGENA webinar. And we will directly start. Today, I will present you the extraordinary novel therapeutic tool from an Ovesco Endoscopy. And this is for the removal of difficult to grasp tissue and foreign bodies in the gastrointestinal tract. But this is not only a product presentation, or it should not be advertising, but I would like to use this opportunity also to show you some tips and tricks for utilizing this instrument. So we will start with some facts about this new device. The OTSG Xcavator is suitable for the standard gastroscopes with 9.5 to 10.5 millimeter outer diameter. And when you open the scoops, sorry, the presentation is not running. Okay, now it's coming. Thank you. If you open the scoops, the maximum scoop span is around 28 millimeter. Now, the actuation line of this instrument is on the outside of the endoscope, so the working channel of your endoscope is freely accessible. Why this could be an advantage, I will show you in, let me give 10 seconds. The maximal outer diameter is 14.3 or 15.5 millimeter of the mounted instrument. And why this range? This depends on the endoscope you're using. So the Xcavator, it adds up approximately 4 to 5 millimeter to your endoscope outer diameter. And the thicker the endoscope is you're using, the thicker is the outer diameter of the whole system. The material, you can see these are transparent scoops, are from a highly transparent material. And on the tip, there's a small hole, so you can use a guide wire with this closed instrument. So as promised, what about this external actuation line? The working channel key is freely accessible and freely usable, even if you have the instrument mounted. So this allows the usage of extra instruments, and this also allows you to utilize the maximal irrigation and section capacity of your endoscope. Just as an example here, we have laid on guide wire inside of the endoscope or some forceps. Of course, you also can use a snare, and this combination of a snare and the excavator is really sometimes useful in certain situations. So, as mentioned, the OTSG Xcavator fits on the standard gastroscopes, and with this video, I will show you how to mount the Xcavator on your endoscope. So as a first step, there's a small tube coming with it and a sleeve. So you slide the sleeve over the endoscope and mount the cap. And now this is one important step. Check the alignment of the working channel and then correct the position of the cap if necessary. So I will just make a short break here. Here you can see the working channel. And there are stoppers in the cap. So shove your endoscope completely to the stoppers for the best view and for good mounting of the Xcavator on your endoscope. And this is really a prior check that the working channel is not occupied or covered, partly covered by these stoppers. Oh, now it comes again, sorry. So again, the alignment, if it's covered, correct it. Now this looks good. The working channel is free. Some of you may know the FTID system, and the further setup is really similar like the FTID system. So you've got a sleeve, and first you secure the end of the sleeve with about 2 to 3 millimeters distance to the cap with an adhesive tape. The next step, unroll the sleeve by just pulling back the tube and remove the tube from your endoscope shaft. So to prevent wrinkles, fix the sleeve with additional adhesive tapes and place these adhesive tapes at intervals of approximately 20 centimeters. So it's really the same with the FTID system. And voila, you are done. So this is how to mount an endoscope. But if you prepare your operation room, there are also some tips I would like to share with you. And with these tips, you will have a stressless and relaxed intervention. And this is especially when you perform a necrosectomy. And now the setup will be for necrosectomy mainly, but you also can use this for blood clot removal or foot bolus infection removal. And this is a similar setup. So first of all, have some water cups available, and then use a syringe with at least 20 milliliter and prepare it and fill it. This can be used for flushing your endoscope via the working channel. Then, of course, some refill water, some tissues, and Q-tips. So why should have everything of this prepared? So first of all, the cups with fluid for flushing the working channel of the endoscope. And if you perform a necrosectomy, you somehow have to flush out the tissue you are grasping. So have fluid available. Then the next step, the flushing pump. If you have it, prepare it and connect it to the endoscope. Or if you don't have it, use a syringe and pre-fill it. And I always like to have an extra syringe, so it's easy to swap syringes with the physician. Just regarding the size, take care that the syringes are not too small, or you won't be busy all the time with just refilling the syringes. Of course, a fluid bottle for refill. Tissues. Why to use tissues? On the first hand, you have to wipe dry the endoscope before you mount the excavator for the best mounting, for the best grip of the cap on your endoscope. And the second thing is, if you have the endoscope and there is some tissue on the cap, it's really nice to have some tissues. The Q-tips, they are just extra. If there's tissue really stuck in the cap and you can't get it out by flushing. And this is really not often the case, but if it's the case, you will be happy to have some Q-tips on hand. Then, these are not in the image. I recommend for you to keep 2 instruments for the working channel of the endoscope available. So the first one is a dilation balloon. Why to have a dilation balloon available? If the access into a necrotic cavity is too small, be it that the hole is not big enough or that the lens is not completely expanded, it's a good idea to have a dilation balloon on hand. And you can use the dilation balloon with your endoscope, even with the mounted instrument, because the working channel stays free. And also have a snare available. This can help you if you want to grasp necrotic tissue that is really hard and you can't grasp it with the excavator because it's too strong connected to the healthy tissue. It sometimes may be helpful to have a snare on hand. But these are just eventualities. So don't open these yet, just have them available, because in most cases you won't need them. So how does the view look like from the endoscopist? And I brought you one example. This is also a transgastric pancreatic necrosectomy. And here I can show you how everything works out. So this is the pre-imaging. Here there was a 60 millimeter lumps pre-lane. And this is the view in the necrotic cavity. And you can see there's a lot of material, a lot of solid material that needs to get out there. So now this is the view with the mounted instrument when it's inserted into the patient. And you can see how good the view is through this highly transparent material, especially when you have tissue contact. You can nicely see through even when the scoops are still closed. Also, inserting the instrument is really easy because it has a conical shape, so it's easy to insert and also to enter the necrotic cavity. Yes, in this case, the physician, he tried to grasp some tissue first, and you can see it's really squishy, it's not solid, you can't grasp it with a grasper. So he uses the excavator, and firstly, he's opening it a bit to get a better orientation in the necrotic cavity. And then next step, aim for the necrotic tissue, grasp it, and the grasping can be supported with a little bit of suction. So even here again, aim for the tissue, grasp it, and then with a little bit of suction and then close it, and you will get enormous bites of tissue. And here, just because it's so beautiful, after several graspings, again, the introduction into the patient, and even though the view is not as good as initially, it's still really, really good if you follow the right flashing techniques. So now this is the view directly after the intervention. And you can see the necrotic material is out. And I would like to stop here because I would like to highlight something. You can see here on the left side, on the right side, the healthy tissue. And then going right through the necrotic cavity, there's a big vessel. So if you have the excavator in your hands for the first time, have a look at the shovels and you will see that the scoops, they are blunt. And they are deliberately blunt to protect the healthy tissue from getting harmed. And here in this case, this was a perfect example. We have blunt scoops to grasp the necrotic tissue, but to prevent injuries for the healthy tissue, because in such a place you don't want to cause a bleeding. And this works out pretty nice. So when you use the OTSG Xcavator for the first time, the handling may be a bit unusual because you don't have an independent movement of the grasping and the endoscope, because the cap is mounted on the endoscope. But you will get used to it very fast. And even if the first intervention maybe may take a bit longer, I can promise you with the second and third intervention, we will be much faster. But for a successful initial application of this instrument, I brought 2 extra tips for you. So there are 2 techniques we developed, and these really help you in your practice. So the first one is the sieving technique. This is especially helpful if you want to suck out fluid, but if the fluid accumulation, there are already more or less solid parts in it. For example, blood clots, if you do a blood clot removal or necrotic tissue. So for the sieving technique, you use the excavator, you close it, and then you start sucking. And here in this example, you can nicely see the fluid is going down, you're sucking effectively, but you don't clutter your working channel, and you also don't clutter the inner of your instrument. So when you want to suck out fluid parts, close the excavator and then suck through it, and this really helps you. The second thing is, when you have a necrosectomy, you may get tissue stuck in the scoops. In the cap, it's clear, you can simply flush it out, but if you open it, you can't flush it out of the scoops because the fluid is running just through it. So there's this washing machine technique, I'm calling it. So for this, start irrigation, close the excavator, and then start the irrigation, and inside of the cap, you are creating a small vortex. And this will help to loosen the tissue stuck in the scoops, and then with constantly opening and closing it with strong irrigation via the working channel. So in this case, with a syringe, you also can use an irrigation pump. Using this technique, you can easily clean the scoops of the excavator. So close it, start irrigating, fill the cup, and then open and close it. And this may need some practice in the beginning, and like always, a good communication of the nurse with the physician. But this really will help you. Also, oops, I don't want to run it again. Okay, whatever. Especially if you perform this technique intracorporally, it helps. But if intracorporal cleaning is not successful, you may have to remove the instrument from the patient for cleaning. And now I want to come back to the prepared operation room table. We have cups prepared and we have the Q-tips prepared. So for cleaning outside of the patient, just shake out the excavator and the cap in a cup of water, And in worst case, you can use the Q-tips for cleaning. So now the main focus was on necrosectomy now, but these tricks also can be utilized when you perform other procedures, like, for example, blood clot removal or foot bolus removal. The excavator is always a good idea to use if you have squishy, elusive material that is hard to grasp with other instruments you're currently using. So I'm already at the end of my time. I just want to give you a quick recommendation. If you want to see more clinical examples, check out our website or also our YouTube channel. Okay, I lost the control over. Can you please take one step back? Thank you. If you want to see more videos, check out ovesco.com. There you see a lot of videos for the excavator, also for other products. And also follow us on social media. We are regularly posting clinical videos and news. And if you want to get in contact with us or have further questions, do not hesitate to contact us via the website, be it via email or give us a call. You also can write us a letter. We are always here to help you. And now we have the opportunity that you can directly now give me some questions. And I think Ulrike will post these to me.
Yeah, Simeon, thank you very much for the very instructive presentation. There was already the comment very clearly explained. So you did a great job. Yeah, thank you very much. Yeah, there are some questions, no, Wendy?
Nice.
Yeah, there is some questions. And one of my colleagues is asking about the flushing, what you used to flush with. Is it okay to use hydrogen peroxide, or you just flush with water, or what do you use to flush with?
Well, usually we just flush with water or sodium chloride solution, what you have available. If you want to flush with peroxide, you can use it. It's no problem for the excavator. The material is resistant for this.
Okay.
Can I also use it with colonoscopes if I have indications to use for colonoscopes and also for pediatric endoscopes, or is it more for the standard endoscopes?
Currently, it only fits on the gastroscope, so with an outer diameter of 9.5 to 10.5 millimeter. But we also had cases where it was used in the lower GI, and you can just use a gastroscope and take the way down. But currently, it's only one size that fits on gastroscopes with 9.5 to 10.5 millimeter outer diameter.
Mm-hmm. You nicely showed to use it with the necrotic cysts. Can I only use it when I have the opening with a lamp, or can I also use it without that?
Yeah, definitely, you can use it without lamps. It works really nicely actually without lamps because you've got this conical shape, and then you can easily tunnel into the necrotic cavity. Only one tip: if you are using the excavator for necrosectomy without a lamps, you will have pigtail stents before. So don't remove all pigtail stents, leave one pigtail stent in place, because then you will easily find the insertion into the necrotic cavity again. And if necessary, I mention it, if the access hole is too small, you can use a dilation balloon via the instrument and through the excavator. And then also
we saw this central lumen for guide wires and so on, no?
Yeah, for guide wires or also for a dilation balloon. Just open the scoops and then go through it with the dilation balloon.
Any further question from your side, Wendy?
There was one question, but I would assume that, I mean, if the instrument is reusable for the same patient, I'm not quite sure why one would do that. It is a single-use instrument, I assume.
Yes. It's a
use it and then you throw it away.
Yeah, the problem is if we keep it over the night or something, you have a mess of germs on that instrument. So that is not really recommended. So it's single use, yeah.
It comes in a packaging unit of 2, so you always have a second instrument available.
Okay.
And And just let me check the chat to see if there was any other questions. I don't believe there was at this time.
Do I have also problems, perhaps if I use it not for the cyst, for the necrotic cyst, but perhaps for food bolus or something like that? So as a foreign body removal, do I also have difficulties to close the instrument again? Is there any trick if too much residuals are in that?
So usually when you use the excavator, and then it's the case because you can't grasp it with snares or with graspers. So it's already really elusive. So I have never heard of a case where the excavator was used and the material was too hard, because then the thing is you can grasp it, and even
just then hold on to it.
Yeah, then you can hold on to it.
And then I can remove it.
And then you can remove it.
Yeah.
Yeah, of course, if you if it's open and then you would like to grasp it and it's too big, yeah, but then you also won't be able to grasp it. So there's no risk.
Yeah.
Yeah.
Good. I would say thank you very much.
Thank you.
Yeah. Perhaps we come back a little bit later, so you will stay with us, and if you have questions, we can.
Yes.